Hey folks, we're back. I'm your host, BKP, and it is time. We're at Circuit World here in Blue Ridge, Georgia. It's time for Ask the Doc. I have a doctor with a hammer.
Sorry I'm late this morning. I know it's cold.
I got this to hit you in the head with because you weren't here yet.
Here, didn't you say we need to move inside because it's cold? In the meantime, I'm dressed full Caribbean here, so I'm ready.
Ladies
for
and
summer.
gentlemen, it's cold in Blue Ridge, Georgia.
Actually, I like this.
I went to the office this morning because I left some of my stuff, and I sat at the computer, and when it was cold when I left, I brought this. We're sitting here waiting for Ray, so I got this tool they use here at Circuit World. I guess they use this on the televisions or
No,
something.
we check reflexes with that.
That's not a reflex hammer. That's a you're late for your TV program hammer. There, I'll put it back over here. And there's a lot of things that are going to happen this morning. One, there's some stuff in the news. We're going to end a little bit early so Dale Green can come talk about the Toys for Tots. But the questions that we have today, part of our answers are going to be to try and dispel some misconceptions, maybe. I'm not going to say myths, and actually give a little credence to some of the conspiracy theories, I would say, or the misconceptions about the etiology of certain malignancies. What do you think? You're over here playing.
What do I think? I'll tell you what I think. By the way, this is Ask the Doc with Dr. William Whaley and Dr. Raymond Tidman, and we always thank Georgia Cancer Specialist, Northside Hospital Cancer Institute for our segment. Now that we've officially announced the segment, and
I'm cold and he's not. See, that's age.
You're loaning your blanket.
Look, it's 43 degrees.
There was
and
ice on my window yesterday because
exactly.
it was 38 degrees.
No, I had 32 at my house. I literally I went out and measured it with my laser thermometer.
Do you have a laser thermometer?
Yeah.
Did they give that to you like free when you bought your electric bike?
Yeah.
Did they? I just didn't know
Anyway,
if
so yesterday
I didn't know if the thermometer came with your
This is the
electric
truth.
bike.
There was ice on my windshield yesterday for the first time. Okay, let's go to work. You ready? My wife is 55 years old, and 8 years ago she had abdominal pain, and at colonoscopy, an ileal carcinoid tumor was found. I'm going to talk about that in just a minute. Surgery removed a 1.5 centimeter tumor. And okay, Ray's the physicist and the rocket scientist here, and so for everybody, 1.5 centimeters is not very big. 2.5 centimeters is an inch, so it's a little bitty thing like that. And she had a cancer operation and not an incidental operation because they took out 33 lymph nodes and 2 had cancer. So tiny tumor, big resection, only 2 out of 33 lymph nodes were involved. So how many percentage is that, Ray? It's about 7% or something.
Yeah.
So a scan was normal. Now they're going to talk about them. This is 8 years ago because what insurance pays for changes, and so what you have to hook your head to when you're going to be monitoring things is what can I get paid for? In other words, you used to just have a chest x-ray because it didn't have the new technology, and we got CAT scans you could do things with, and then you got PET scans. So if you used to use a chest x-ray and now you're using a CAT, so anyway, doctors have to think about what test am I going to use to monitor this particular patient because tests change and things that insurance companies pay for change. But anyway,
Bill, let me pause you there for a second.
Well, that's what you're here for, so pause me.
2 and 32, so 1 in 15 lymph nodes were positive. So how do you think about that? Do you say, oh, okay, well look, more than 0 are positive, therefore it is out of the box?
Yes, that's right, it's out of the box.
That's really what matters. It's
Yeah.
not so many how many.
Well, yes, that matters also because what you know about the resection is, like with breast cancer and the sentinel node, the ones in a breast cancer are generally close to the tumor. So you got another 25 lymph nodes. You've done a pretty good job if it's going to be moving from lymph node to lymph node of stopping the progression. But it was in the lymphatics, and therefore it can have circulated in the lymphatics. And since this type of tumor grows so slow, it could come back in 25 years. So it's not like some things where if it's not back in 2 years, it's probably not going to come back. So anyway, she had regular follow-up for 6 years. So where she was, they were doing CAT scans or something for 6 years. We moved to Georgia, so I think they've moved up here. She has developed, now this is primary care thing now. She's stopped thinking about her tumor. It's 6 years out. They're through doing scans. They probably released her, told her to come back in a year, and then she moved. She has developed iron deficiency. Endoscopy is negative. Okay, that's over. Her PCP's already done an upper and lower GI endoscopy, except for mast cells on colon biopsy. A CT scan is negative. She has a history of anaphylactic reactions to penicillin, bee stings, and several unusual medications. So this patient has sort of an allergy, hypersensitivity history, had a tumor 8 years ago that's associated with recurrences that are heralded by allergic reactions, flushing, itching, and things of that sort that would have, in a patient who'd never had this tumor, been sort of linked to the allergic-like history, but for an oncologist is gonna make him a little more suspicious that these reactions may be, particularly flushing, itching, and that sort of thing, are related to the tumor. We're gonna come back to that in a minute. We are seeing a new oncologist who was encouraging, but has ordered a special type PET scan and a 24-hour urine. What is he thinking about, and can you tell? Well, first of all, we're going to talk a minute about the chronogranin A, which we know was elevated at the original tumor, and now this doctor's talking about doing a 24-hour urine and not mentioning that chronogranin A. I think that's part of that question, because what's he thinking? He's ordering a urine, he's not doing something else, and talking about a special PET scan. So show that first one. This is a real common, if you go to the emergency room this weekend, you've had too much popcorn, and you're watching a ball game, and you get a bellyache, and they think you've got appendicitis, and they do a CAT scan, and you're roughly our age. If you're a teenager, you got appendicitis. But if you're 30 years old and they see this CT scan, this is a CT scan right there, there's the appendix, and that little bitty spot, the radiologist would look at that and say, this looks like appendicitis, but, pull that down now, but it's got a little spot in the middle of it. So this patient originally had abdominal pain and colonoscopy. They were thinking appendix, I'm pretty sure. And he took his scope and he went all the way in the ileum, which means he went up there past the appendix, which comes off the ileum at the cecum, and found something like that little spot. It doesn't say that the CT scan showed it, but that either of those two things could have showed it. So they removed it. And it was a carcinoid tumor. Okay, show the next one. This is just an elaborate chemical thing. We're not going to spend any time on it, but over here in the top where it says carcinoid tumor cell, it produces these various hormones. You don't care what they are. You can pull that down now. But those hormones are inflammatory-like hormones, and when you get stung by a bee, or you have an allergic reaction to penicillin, or some other reaction where you flush, you can't breathe, or you wheeze, your normal cells in the body, and that's why he mentioned the mast cells on the colonoscopy, pour out histamine and other chemicals that cause those reactions. Well, if you look in this, when you get to way down here to the bottom, as your body processes these things, this chronogranin A is just a metabolic byproduct of the metabolism of those types of things. And 10 years ago, we used to, before we had some of these new CT scans, we used to use the chronogranin A level, kind of like a PSA level or a CA125 in ovarian cancer, and if it was elevated and rising, it put us on the suspicion for recurrence of this tumor. Now put up the next one. You gotta always know what's gonna confuse the test that you're doing. So you'll remember in the past I've said about a guy whose PSA was 10,000, but it was caused by being in a bicycle race and bounding his prostate on the bicycle, and that wasn't cancer, so that confused the blood test. These are the conditions that have been shown since in the last decade to be associated with increases in chronogranin A, and it goes through 3 blinking pages here. You can pull that down, but about 25 of these things are present in lots of people. Chronic bronchitis, I'm coughing today. We've all got a cold. Inflammatory reactions, proton pump inhibitors. Lord have mercy, we got so many people taking these drugs for gastroesophageal reflux that basically the insurance companies don't pay for this anymore, and the fact that they don't is probably not wrong. And if you're just hanging your hat on that chronogranin A level, then you're going to get in trouble because too many things overcome it. Now,
It's too non-specific.
too non-specific. It's really helpful back when it was the only thing you had, but now you got better stuff. So now if you look at this next one here, so this patient has had this anaphylactoid type reaction and has had the flushing and the itching and everything. And so now I'm going back into the primary care. Ray's in his office. A woman comes in and she's complaining, I'm having spells of flushing. I flush and I itch, or I get a little short of wind. And he pulls out this little thing out of his little book, and he's got over here what's the top thing on the list?
Menopause.
Menopause. What's the next one?
Hot drinks.
What's the next one?
Emotional distress.
What's the next one? Anaphylaxis. Anyway, point is,
Anaphylaxis.
that means that's that bad reaction you have when the penicillin shot. And then you get into drugs. What's the first one?
Alcohol.
Then you get way down here to all these drugs, lots of drugs that people are taking. And then you get to what diseases. What's the top one? Carcinoid syndrome.
Carcinoid syndrome.
What we're talking about today. And then the next one is mastocytosis. That's what they saw in that colonoscopy. So, pull that down. So this patient may be taking a PPI. We don't know. So anyhow, the doctor is going to focus on the things that cause this type of reaction that are not related to chronogranin A. Okay, put up the next one. He's getting ready to order a fancy kind of a PET scan. Now this is a real pretty picture, nice beautiful colors there. This is a liver in a patient with a carcinoid tumor, and this is a specific antibody that links to somatoceptin receptor. Pull that down again. In other words, it goes specifically to a protein on the surface of a carcinoid cell. A few weeks ago, I talked about a new sort of PET scan that had a link that would hit a prostate cancer cell that was different from regular PET scanning. Next one. This happens to be the picture that you see of that's four separate kinds of PET scans with different labels only for carcinoid. So you can pull that down. So you can see that all of those are confusing because each one of those has a different mechanism to take that radioactivity to the cell. The one that this guy is clearly ordering is the one that's hooked to an antibody that goes to that cell, and that's the newest generation. That shows you 4 generations. So now, we're worried about, put the next one up, we're going to not spend a second or two here. What's this guy looking for? What he says, what is he thinking? So that's what he's asking me. What's he thinking? So what you got here? Algorithm. Okay, this is a long 3-page algorithm. When you are suspicious that you have metastatic recurrent neuroendocrine tumor, your first order of business is to try to figure out, 1, is it there? And 2, if you can, what do you want to do? Resect. What's resect mean?
What?
Resect. That means operate, remove. When in doubt, cut it out, right, Ray?
It's a surgeon's byline.
Yeah, when in doubt, cut it out. You don't like that one?
Chance to cut's a chance to heal.
Chance to cut it. When in doubt, cut it out. Now that's 50 years,
Yeah, that's a
60
long time
years
ago.
we heard that thing, right? Okay, so here's what he's trying to do. The 24-hour urine was back on that prior slide, where he's looking at the urinary product of all of those different the chemicals that can cause you to flush, but only the specific one that's made by the carcinoid tumor, and you don't care what it's called, so it's 5-hydroxyindoleacetic acid. But anyhow, that is a specific test, and importantly, the insurance company will pay for it. And there are very few confounding, compounding, or confusing things that would make that abnormal. So if it's high and abnormal, you got pretty good information. Somewhere in that body, there's some carcinoid making all that tryptophan stuff up there. Now, the next thing that you want to know is, what is he thinking about once he finds something? So I'm just going to throw this up, put it up. This says, non-randomized, randomized trials of novel agents in advanced neuroendocrine tumors. If you look at this, this is 1, 2, 3 big long pages long. Pull it down.
Of treatment things.
Huh?
Of treatment options or diagnostic
Treatment options
Okay.
with targeted, genetically driven, non-chemotherapy, non-surgery, non-radiation treatments.
All right, I want to pause you again here.
That's what you're supposed to do.
So, well, first of all, we made a sideways comment about our surgical brethren, and that just speaks to the fact that within the medical community, we push around, push back on things, debate things, and sometimes we use humor. But in California, if you don't say the right thing, they're going to pull your license. So, medicine's changing rapidly.
Well, in Georgia, they'll pull you up before the board.
Pull you up before the board and interrogate you. In California, they're just going to pull your license. All through building our professional careers, physicians are they push back and they question things, and that's part of life. That's part of being a scientist. Things are changing. But back to this issue, Bill had this lady come in without the history of melanoma 6 years ago.
Carcinoid.
No, but
Yeah,
without her previous tumor history,
Yeah.
would she be being put through this level of a workup?
No, you'd be doing this. Well, first of all, she's iron deficient.
Yeah, the iron deficiency and the itching are worrisome things.
She's going to get iron.
Yeah, she's going to get
already
therapy.
Had the colonoscopy,
and the iron may fix the itching. But these patients come in and they're itching all over, and it keeps coming in waves, and it drives primary care physicians because you're like, well, how much should I put her through to get to the bottom of this? But it's the previous cancer history.
Yeah, let's go back. Go back to this now. This is a non-cancer patient. I've got a friend that y'all know me. I've spoken about it because he bought Aspen Snowmass Company out of bankruptcy as a hobby. But his wife has recurrent episodes over 20 years of angioneurotic edema, flushing and itching, this type of thing. She's been to the Mayo Clinic, she's been to the Oxner Clinic, she's been to just about every allergist there is. And once Ray's gotten through, look, why don't you start eating strawberries, get on this kind of eat a simple diet of oatmeal, toast, and eggs for about a couple weeks and see if there's something you're allergic to. He's going to have to send him to an allergist. And there's lots of pathways you end up going down. There's only 1 or 2 pathways that are going down that are malignant. One of them is the carcinoid, and the other is the mast cell. But if you got 100 of these patients in a primary care doctor's office, 95 of them are going to end up food
benign.
allergies.
It's going to be benign. Yeah.
Well, yeah, and a quarter of them you're never going to figure it out.
Right.
And neither is the Mayo Clinic or any allergist in the world. It's going to go away. Well, that was good, Then 10 years later, it comes back. Anyway, so we're going to come back now to this PET scan that we had back 4 or 5 slides ago. That was an antibody specifically that hooks onto the cell of this particular tumor and carries an isotope that makes a picture. All right, put up the next one. This, you want to read it out with me? Do it. peptide receptor radionuclide therapy. That's
That's a mouthful.
PRRT. This is a concept that I have mentioned on a bunch of occasions over the last couple of years. One of them is metastatic cancer in bone with pain, where you give radioactively labeled sort of strontium that goes to the bone. It doesn't make a difference what kind of cancer it is, because the radioactive particle only it penetrates fractions of millimeters, and it kills off the cancer cell without bothering the rest of the body. But this concept here is, you see this bottle of blood over there and this thing here, pull that out, go to the next one. All this thing is some clever chemist or physicist from down at Georgia Tech. I always use Georgia Tech, right? He figured out that if he got the next one up there, that if he takes this antibody that you were using for the PET scan, and you can find a way to glue it to a source of nuclear energy, not diagnostic but therapeutic, and then infuse it into the blood, that it's going to go around and hook to that tumor cell. And since I don't know what's the alpha particle that goes only a thousandth of a millimeter, gamma rays go through your brain and alpha particles don't penetrate much, it'll just kill the tumor. So put the next one up. So what this guy's doing, that's this whole algorithm. You can pull that one now, it's too confusing. But what this guy's trying to do is, with this fancy PET scan, he's trying to find something that may be localized there that the surgeon can take out. That would be the best if he found that where those 20
So with this labeled isotope, he's going to specifically identify exactly where this is and where it is not.
In all hopes.
In all hopes. That's his hope.
Now, so the best outcome here would be that PET scan shows a spot somewhere near where the surgery was done, and as Ray asked, it's out of the box, but it's 8 years later. So if had 2 lymph nodes positive 8 years ago, we could imagine that there's a lymph node that had a few cells in it that wouldn't have shown up and was not removed, that 8 years later has gotten big enough to put out some of these chemicals that make the patient itch and flush and so forth. And that's the best of all possible worlds. And you find one spot, well, she'll go back to that surgeon, it'll be removed. It may be another 8 years before anything happens. The second thing that could happen would be that you get that PET scan that shows multiple spots in several locations, in which case he's going to do one of these treatment options I just showed you, either the radioactive one or the drugs. That's going to depend on the patient. Or lastly, that PET scan doesn't show anything, and so there's no surgery he's going to be planning to do. There's no spot where he thinks he can put that isotope, but that 5-hydroxyindole acetic acid level is way off the chart. So now we know that there's tiny areas of tumor in that body not big enough to detect, and then he'll come along with something simple that will be systemically active, that will go and hit that cancer cell, and that happens to be called Sandostatin. So he's on the right track, and the fact that he didn't order chronogranin A level, I think I've figured that out for you. But clearly he's trying to find the easiest treatment for your wife if this is related to recurrence and not related to the underlying allergy that you reported she had for so many years. So your wife's in the right hands, but this may end up being an allergy and not malignant at all. Okay?
I want to emphasize that, out of the 100 people you mentioned that come in with symptoms like this, 95 of them, it's going to be things that we don't know. It's going to be the famous Latin word idiopathic. I hate that word.
Makes an idiot out of the pathologist.
Yeah, the pathologist. So, or it's one letter longer than the phrase "I don't know." The bottom line is that for most of these people, it's important that they go to a senior, studied, experienced physician to nuance this out. Now, I'm being a little bit biased against my younger brethren, but trying to tease out of how far to push this and how many tests to do and not drive the patient crazy or neurotic is a very, very artful thing to do.
It is. Well, there was a guy in Atlanta named Skip Wiegand who was the world champion weightlifter over age 65 and who saw his patients from 5:30 in the morning till 11:30 in the morning. I've talked about him on this program before. But his office was full. He was a dermatologist for business people who wanted to be there at 5:30. Anyhow, I had a patient with him probably 40 years ago. Went to the Oxner Clinic, one of those places that this other woman had gone to, that was allergic to the red food dye 23 or something. Remember that?
Yeah.
And eliminated everything that had your apples you buy at the store that have that stuff on them who got the red food dye in it. Anything you've got that's red that you eat that comes out of a store has got the red food dye in it. Eliminated all that. She did really fine for 2 or 3 years, and then started having them again, and she hadn't added anything back, and it turned out that one of the Pepsodent toothpaste or something had put red food dye in their toothpaste to alter the color. I forgot, Pepsodent used to be yellow or some other color, and it was in her blinking toothpaste. So you want to talk about something complicated. That's way more complicated than Ray and I would ever figure out.
Well, that's very nuanced and very complicated. Let me tell you the obvious that equally drives you crazy. I had a young lady come in with severe hives-like reactions, requiring hospitalization twice for IV steroids. She's like 14. And every time she'd come in, we'd go through this total list of what's new in the house, what's the detergents, what have you changed. Mother would just be pulling her hair out, trying to figure out what this is. Well, like the third, and I'm scratching looking at her. So it was like the third admission, and we went going through the history again. And I said, "Well, what'd you do yesterday?" And she said, "Well, I went out and tended the horses." I said, "Well, what do you do with the horses?" "Well, I put the powder on them and brush it all in, all that kind of stuff." And I said, "Well, what's the label on that powder?" You know, it's got skull and crossbones, and it's got some pretty long chemical names on it. And I'm like, "Do you think that could have been it?" Because that's all she's done every time she's had this reaction. But sometimes it's that Easter egg that's on the post right in the middle of the front yard that the kids never see. It was like right in front of our faces. We'd looked at everything else, but the most obvious poison toxin thing in her life, she could not think of.
Wow.
So,
all right. Well, we got one more that's going to be relatively quick.
Are you able to get this in and get your news of the day?
We'll pick it up. Let's pick it up next week.
Okay. Because I know you have news of the day, and I don't want to.
We got to let Dale Green in here because he's a big shot.
I don't want to. I don't want to disregard.
That's your job. Keep us on track here.
Go, keep us on track. Okay.
Well, I want to be fair to the question and not have to.
Yeah. Okay. I'm gonna save it then. All right. So what we're going to do now is we're going to give up the floor. Dale Green.
All right. Well, wait a minute. Okay. All right. We're going to
give up the floor.
Do you have a closer? Nah.
No, I came in.
I've got one.
I came in hot.
Oh, okay.
I've got one. What is this?
That's your tie.
Are those insects?
Oh, those are ping pong paddles.
Ping pong.
And it looks like a mug of beer that has 62 on there. Okay. What's the point?
All right. Well, this is Dartmouth class of 62 tie, remember?
All right, okay.
School just restarted.
All right.
What's the most famous movie about school and
Animal House?
Animal House.
Okay.
Animal House was written about the class of 63 at Dartmouth by 63. John Belushi plays the part of one of my classmates who's still alive, who was the character in the book. But beer pong was invented in the basement of the AD fraternity house at Dartmouth. And this is the first week of college classes all over the country. So I'm wearing this so all you people who just sent your freshmen off to college in the last couple of weeks can worry about whether they're in the basement of a fraternity playing beer pong or not.
Do you know how to play beer pong?
I think it requires beer and foam.
Yeah, I want to know the truth. Inquiring minds want to know.
Yes, I do know how to play.
You know how to play.
But let's not get into it.
But I tended bar there. I did not play.
Now, did you ever have to like double bounce, or just one bounce? Did you ever put up Like it has to have 2 bounces? Or?
No, they'd have no. The only rule is if it gets in the cup, you got to drink it, and they're not gonna make it hard. They're gonna make it really easy.
Huh?
So I mean, you could almost walk over there and
stand over it, just drop.
Do you?
It's got to be hit. It's got to
Do
be hit.
you know what beer pong is?
I've never played. I'll have to tell you that. So.
Okay, good.
Well, I'm going to send you the rules of beer pong in an email today. So anyway, we got to give way to Dale Green, U.S. Marine
Folks,
Corps.
we're going to take a break. We want to thank our doctors, Dr. William Whaley and Dr. Raymond Tidman. We want to thank Georgia Cancer Specialist, Northside Hospital Cancer Institute. I'm going to back out of the way because Rick Glickard. We do this every year, and Rick's here every week, and he knows the drill. And these are all good friends of ours, but we support Toys for Tots, and every year we bring them in and give them an opportunity to share with you the upcoming program for the year. So right after these messages, Rick's going to step in with some friends, and we're going to give some time to Toys for Tots. Then the All-Star Political Panel. Take a break.